nutraceuticals on infertility today. When we talk about nutraceuticals, a lot of terminologies come into our mind, like micronutrients, antioxidants, and many other pharmaceutical products. So why should we know about nutraceuticals? And do these antioxidants really play a role in improving the fertility? So let's begin with the basics. Nutraceuticals is a term which is defined as nutrition and pharmaceutics. So these terms are actually applied to products which are herbal, dietary, or processed food like cereal, soups, etc. And these products are used as nutrition plus medicine. So that's why they are nutraceuticals. For example, all of us have used ginger a lot, especially even in pregnancy. We say if you take ginger, it works like an antiemetic. So ginger here is now nutrition plus ceutical. So it is a nutraceutical. The second terminology which comes to us is micronutrient. So micronutrients are chemical substances, but these are the chemical substances which are now required by our body in trace amounts. So our body does require some chemicals for normal growth and development. So when we used to think about it, micronutrient was like an umbrella term which is now used to actually represent all the minerals which are required in our diet for cell signaling, motility, proliferation, differentiation. Then the next terminology came to us was adjuvants. Anything which you add apart from the normal is an adjuvant. So adjuvant is serving to aid or contributing to your normal treatment. So why do we need these adjuvants in infertility? Multiple adjuvants can be used for improving quality and quantity of oocytes, improving the endometrial thickness, embryo quality, maybe improving your live birth rates, and of course decreasing the medical complications. But when we talk about all of them, the list keeps going on. So where, when, and what to use is something as clinicians we all should understand. Whenever you plan to use any adjuvant, you should discuss it thoroughly. You should know about it thoroughly. Does your patient actually need that adjuvant? And can your patient actually afford it? Because even adding a small tablet to your prescription can be an added expenditure, because these adjuvants are not very cheap and maybe cost 75 to 100 rupees per tablet. So if you give them for 3 months, you can imagine it's an added expenditure for your patients. And you also should know the evidence behind using any adjuvant. Our country is very prevalent on multiple micronutrient deficiencies. And maybe that's why we are seeing a rise in infertility. And because of these multiple micronutrient deficiencies, medical complications have also been increased. As clinicians, we have been neglecting a few micronutrients, and suddenly nutraceuticals came up to picture in the last few months, especially after COVID, because we understood that there are some micronutrients which now deserve the attention, because studies have shown that these deficiency states are related to poor pregnancy outcomes. When we talk about infertility, we know it's the failure to achieve a pregnancy within 1 year of regular unprotected intercourse. But in 50% of our couples who come to us for an infertility workup, no major cause for infertility is found out. That's when personalized management strategies come into play, especially in cases of unexplained infertility. So unexplained infertility is a diagnosis of exclusion, where your routine, standard, basic investigations showed no abnormality. And that's where these micronutrients, nutraceuticals might help us. Certain pathologies which may not be identified can be responsible for subtle changes in causing infertility, especially in ovarian endocrine factors, peritoneal factors, tubal factors, even male factors, and psychological. The 4 common factors causing unexplained infertility can be mild endometriosis, because endometriosis, the accurate diagnosis is difficult. Tubal disease, even if your tubes are patent, there can be tubal function which is impaired. Premature ovarian failure, and subclinical autoimmune disease. Then came the important factors after in the last 2 years. That was altered microbiota, which has been thoroughly studied and has now come into picture saying that yes, altered microbiota is responsible for infertility, is responsible for recurrent pregnancy losses and medical complications in pregnancy. Other factors can be lifestyle and psychological, especially when Sir was telling us that we have to have lifestyle modification apart from adding any adjuvant, and male factors. Oxidative stress is a terminology we have all been using thoroughly since the many years, but we have to understand how it acts. So oxidative stress can be exogenous, that means from outside. So that can be because of obesity, nutrition, alcohol, environmental exposures. Then endogenous where it has affected the reproductive pathology or physiology, and the toxic radicals are now developing from inside. That's commonly seen in polycystic ovaries and endometriosis. So toxic radicals are produced in oxidative stress by two reactions. That's the chemistry behind them. And then these reactive oxidative species actually cause infertility by four procedures like opening of the ion channels, protein modification, lipid peroxidation, and DNA oxidation. And that's how ROS causes infertility or affects your fertility. And that can happen in males and females both. As clinicians, we always measure our infertility treatment in three ways: time taken for the patient who has come to us till pregnancy, outcome, whether we have given her a live birth rate, and of course, cost, and not just the financial cost, but also the emotional cost to this patient. Then we've been discussing nutraceuticals. Let's go ahead and discuss few important ones. So there are two classifications of nutraceuticals: potential and established. Potential nutraceuticals are nutraceuticals which tell us that show some approach that these can be used or may be useful to us, but they do not have any sufficient data behind them. Established are nutraceuticals which have sufficient clinical data behind them to tell us yes, they work. Nutraceuticals are also classified according to the composition. So they can be nutritional function, herbal, photochemical, and dietary. So how do these nutraceuticals and antioxidants help? A lot of antioxidants have been used in fertility, like vitamin E, which improves the epithelial growth in blood vessels. Vitamin D, benefit to the woman, especially in polycystic ovaries. Myoinositol helps ovarian function. L-arginine improves endometrial blood flow. Acetylcysteine actually improves the cervical mucus. Polyunsaturated fatty acids improves the steroidogenesis, and micronutrients like selenium, zinc, pentoxyphyllene actually act as very strong antioxidants. How effective are they? The first published Cochrane meta-analysis came in 2017, and it was a huge trial. 6,510 women were included, and then they published saying that yes, adding some antioxidants versus placebo showed an improvement in live birth rate and decreased your clinical miscarriage rate. That's how nutraceuticals came into picture from the rise from 2017 to now. Nutraceuticals have been used in multiple conditions apart from fertility, especially in allergy hypersensitivity disorders, cardiovascular disorders, cancer, especially in developing countries. It has said that if you are a high risk patient for cancer and there is a history of cancer in your family, some form of antioxidants or cancer preventive nutraceuticals should be added regularly in your diet. So a preventive approach by nutraceuticals is now coming into picture. And of course, diabetes and obesity. Most important adjuvant or nutraceutical which we use now for fertility is coenzyme Q10, and I think all practitioners have used coenzyme Q10. It is an antioxidant which is associated with mitochondria of the cells. So it acts as an energy promoting agent because mitochondria is an energy developing part of your cell. So that's how it helps. It actually eats up all the toxic radicals which are present in the body and helps in energy production and improving the cell energy, so delaying in aging. So coenzyme Q10 has been studied a lot, and it is now said to be an established adjuvant to be used, especially in cases of poor oocyte quality, or if you see fragmentation in your oocyte or
Neharika, your voice is not
Voice is
clear.
not clear. What is happening? I thought it is my problem. Please check me, Harika. हाँ अब बोल.
yes, ma'am.
Now it is okay.
Um, okay, wait. So the next adjuvant which we are talking about was omega-3 fatty acids, and they have been associated with high clinical pregnancy and live birth rate. Selenium, most of your compositions of adjuvants which you give have a little bit amount of selenium in them, and that has been seen because they studied the oocyte which was the fluid which was retrieved from transvaginal oocyte retrieval, and that showed that there was selenium present in them, and that's how selenium came into picture to be added into adjuvants. Lycopene is a powerful antioxidant which can reduce oxidative stress. Vitamin D, personally, one of my favorite adjuvants to be used in women of all age groups because it works from head to toe. It has been working for other conditions also, like for lungs, for breast cancer, for blood pressure, allergies, even other kinds of cancers. But especially in fertility and pregnancy, it reduces the medical complications and improves the absorption of other adjuvants which you are giving. So it's a one kind of drug I think which should be given to infertility and pregnancy patients. Vitamin D has also been studied for polycystic ovarian syndromes, and it has shown to improve the insulin resistance and menstrual irregularities if given to these patients. So it is backed up with a lot of data. The next important adjuvant, which is always on my prescription, is a probiotic, not just for their gastric benefits, but it is also shown to improve immunity, reduce the risk of urinary tract infections and vaginal infections, and helping in other nutrient absorptions. So, probiotic actually regulates the vaginal microbiota and helps in reducing the risk of pregnancy complications. Probiotics have now been studied in infertility, and seeing dysbiosis has shown direct relationship to your reproductive outcome. Myoinositol, D-chiro-inositol also have been shown improving benefit in polycystic ovarian syndrome because PCO, there is an imbalance of these two adjuvants, and therefore adding them to a PCO patient might help in improving the glucose cell intake and increasing your insulin sensitivity. Newer adjuvant which came into now in picture was moringa, and moringa has now shown multiple benefits from antipyretic, anti-epileptic, anti-inflammatory, and antifungal, antibacterial activities. So it is like a big huge functional food. Then we come to poor responders. Poor responders, we know nothing actually really works, but sometimes you have to give them some form of adjuvants. The first common adjuvant which we use is DHEA, and DHEA actually helps in modifying the aging environment in women and improving the steroidogenesis, which might help in improving the oocyte which will be retrieved later. So DHEA reduces the apoptosis and may improve ovarian reserve.
Again, problem in your
Another
voice,
form of androgen
Harika.
is testosterone. Yes, ma'am.
Again, problem in your voice.
Uh, I'll
दोबारा join
actually
करो.
switch off my video.
Switch off video and rejoin. हाँ, yes.
Is it okay, ma'am?
हाँ.
So growth hormone is another adjuvant which is very expensive and is now has very limited use, only especially in recurrent implantation failures where it can be used. And that's where the studies have now told us that especially in RIF patients, growth hormone can be given to improve endometrial receptivity. Then came in some innovations, and these might come to India soon. Innovations are technologies which are now using nutraceuticals according to body type. So a specific nutraceutical will create a
Niharika,
specific
I think your voice speed doubles up. on
हाँ
its
ऐसा
own.
कुछ हो रहा है, डबल हो
Hmm.
जाती है, ये बहुत फास्ट हो जाती है, फिर समझ आना बंद हो जाता है।
मैम मेरा तो सिग्नल फुल आ रहा है वैसे।
चलो अब आप
आई
बोल रहे हो तो बिल्कुल ठीक है, स्टार्ट अगेन देन, देखते हैं।
so so these technologies which have come up actually help in genetically engineering a nutraceutical for you. So fascinating opportunities have been coming up, but as clinicians, we have to understand there is a gap between existing knowledge and implementation. That's why we need to keep updating ourselves. A newest technology which have been recently used is PRP, and we know ovarian PRPs are very safe. Ovarian PRP and stem cells can be used in premature ovarian failure.
Niharika, nothing is audible.
So I'll explain you this. As you can see, this is a, ma'am, can you hear me?
Yes, yes, yes.
So this is a procedure for ovarian PRP. So we are injecting the PRP which is prepared 15 minutes prior, directly ultrasound guided into the ovary so that it improves the oocyte count and quality of the patient, especially in premature ovarian reserve. So this is done ultrasound guided and it's a small procedure, takes hardly 10 minutes and very, very safe to do and has shown tremendous results in premature ovarian failures and poor count and poor reserve. So here you can see the needle going in and then a PRP is injected in the ovary. So other procedures which are coming up is using human menstrual blood or stem cells to treat premature ovarian failure. So a lot of things are coming up for ovarian insufficiency and multiple guidelines have now come up. ESHRE says there is possible benefit of using antioxidants in our day-to-day life. Even by Cochrane, it is now said that adjuvants or adding an antioxidant helps, but we have to understand which adjuvant or antioxidant will work where because we have a vast variety of nutraceuticals. So it is up to us clinicians to know that. So as clinicians, we should be fully aware of the best available evidence and patients should be actually informed about experimental nature of these adjuvant therapy. Thank you.
Thank you, Neharika.
So
That
sorry,
was
ma'am. I don't know what happened to my
हाँ
network.
वो बीच बीच में speed was getting faster, so we couldn't understand what you are speaking. So anyways, on the whole, it was very good and very informative. So much of details of adjuvants which really are beneficial. Some of them are really beneficial actually. So now I invite our experts. So let us discuss the topic with others. Later on, we will take the comments of our experts, final comments from Madam and Dr. Manju and Brigadier Sarma sir. So I invite Dr. Seema Sahgal. Dr. Seema, are you there? I think she was there. Dr. Seema? So Dr. Megha?
Yes. Yeah.
Dr. Megha is there.
Uh, Thank you, Dr. Neharika. It was wonderful hearing you and with a sweet voice. There was some network error in between, but it was lovely hearing you. I think the most important point which I felt was that cost effectiveness of the adjuvants which we are using is very important when we are dealing with IVF patients. They're already undergoing so long treatment with such high cost. So I think cost, we have to calculate the cost of what treatment we are giving and is that useful according to the cost. That point I felt is very important. Thank you.
So Dr. Aruna Saxena?
Niharika, that was an exhaustive lecture and very informative. I just want to tell you, I do vitamin B12 and D in all my patients who come for fertility. Most of my patients are affording, and I found there's a drastic reduction in, I would say, more than 80% of the cases, the vitamin levels are so bad. You just supplement the levels and you'll see the change in the sperm motility and other factors. So that's a very important point, and the supplement is not very costly. So this is my favorite. And besides that, in poor women deserve, of course, DHEA and testosterone is proven by the studies, and of course the CoQ10. As you rightly said, the list is exhaustive and very expensive, so we really have to choose. So my preference is these two vitamins and DHEA, testosterone in poor ovarian reserve, and CoQ10, of course. I don't like to give many other supplements because, as all of us know, it's a very costly treatment otherwise also.
So we have also stopped using growth hormone, madam. Earlier we
Yes,
were
ma'am.
using it, but now we have stopped using it. Earlier in all poor ovarian results, we were using growth
Growth hormone
hormone.
now has a very limited role. If nothing else
Yes.
works, then you might try it for only recurrent implantation failures, nothing else.
So now I invite Dr. Manju Khemani. Ma'am, you are muted.
So what I feel, quite a lot of research, it is, backed by these pharmacological companies. I'm really, really wary of, as Dr. Brigadier Sharma said, that I tell my patient, for lifestyle modification, for exercise, yoga, there is some place for this thing, but that right, left, and center, these druggists come to our room and representatives, and we start writing CoQ10 and all those things. We have to, I think twice, take a seat back. Maybe some good research will tell us. But at the moment, I don't go much for all these things.
So, ma'am, you know
Sorry.
why these nutraceuticals have come into picture is because of the adulteration, which has happened. Our environment has become poorer, and insecticides, pesticide usage has increased. Otherwise, if we were healthier in our environment, maybe adjuvants or these antioxidants would not have been needed. But right now, even our air which we are breathing, we know is very, very poor, and that's why these adjuvants are important. It's not just because of pharmaceutical, but because seeing our environment. If you go to a good hill station where the breathing quality is better, they'll conceive earlier with your treatment.
But
But
Niharika,
Niharika,
how much and how long?
Niharika, my one question to you, right? Insecticide, pesticide, poor diet, it is for 100% people. So why only 15-20%, need it, So that's what I'm saying. I'm not denying, there
No,
must be
no,
some
ma'am.
goal.
Yeah, ma'am, I agree with you. Only why
Huh.
do only 15% need it? Because they are not actually following the right lifestyle also. So it is together which is going on.
Mainly.
It's not just one thing. And
Yeah.
plus all the metabolic disorders, which have, if some of these patients have some form of metabolic disorder also. So these 15 to 20%, especially the unexplained infertility category, is the one which is we have to focus on.
So, Dr. Sharda Jain, ma'am.
I'm the great follower of Dr. Brigadier Sharma. He says, just जो बिल्कुल minimum use करना है बस वही use करो. And this is what has been ingrained in Dr. Jyoti Agarwal's mind. And whenever I try to do something, she will say, नहीं डॉक्टर ब्रिगेडियर शर्मा कहते हैं ये कुछ नहीं यूज करना है. This is what I wish to tell you, but I'm a very strong advocate of lifestyle changes. I do tell them myself about the diet, about the pranayam and the meditation. And I'm very fond of vitamin E, vitamin C, and CoQ10. So
Sir,
over to you, Brigadier Sharma.
sir, your
Thank
final comments. What should we do, and in which patient, and in what dose, and for how much time?
And here I will tell you a tip also. Every year I will call Dr. Brigadier Sharma to give a talk on antioxidants. I will also ask him to give a talk on these kind of things. So he will give his mind to it कि ये करना चाहिए ये नहीं करना चाहिए. And we are ardent follower of him.
I think the first thing we should do is we should ban Zomato, because that is the biggest problem, because that is causing the deficiencies today. So there's like when you said anemia Mukt Bharat, I think we should also have a Zomato Mukt Bharat. That is also very, very important. And having said that, the vitamin D, see, it's definitely it is good, but there is one point which we should remember: the Indian diet. If you give it orally, it may not get absorbed. So you do not get. So at least you give one injection of Ferracetol and then you give orally. So don't give
Yes.
only orally. At least one injection you give it, and then you switch over to the oral. That is a one practical point. And regarding this PRP, it was a very interesting this thing. However, we don't use it. I have just one or two questions, Niharika. At what menstrual stage, you give injections of PRP into the ovary? First.
So usually premenstrual. So when we start down regulating the patient, so I usually do it at around day 21 or 22 of the cycle, just before premenstrual.
Okay, only once you give it.
I mean, sir, it's
That-
only has to be done once. That's it.
Okay, one.
This is
No, no, I'm
ovarian
talking about the
PRP,
ovarian
sir, not
only. And
endometrial.
how much you
Yeah.
inject into the ovary?
So depending on how much PRP you get, about 2 to 4 ml is sufficient.
You give it
In
at
each ovary.
to each ovary?
Yes, sir.
You give it at only at one point, or you just go at various
No,
directions?
sir, we can't do multiple points because then the risk of complications will increase because the needle gets
Because the ovary
inserted into an
size is
ovary.
very
So
small.
only single point in each ovary.
So will the ovary you give say 2 ml will be able to take that much of fluid?
No,
Because I've got no experience. That is why I'm asking.
No, sir, we've just done 5 cases recently and in the last 3 months, and we have seen an improvement. So
No, no,
mostly
no.
we
My
will,
question is not that.
yeah,
My
yeah,
question is, you are injecting ovary is a, having a own capsule and you
yeah,
are putting a 2 ml
That
of
is very
fluid
much.
at one place only. It
yeah.
will be seen in the ultrasound that yes, there is a hypoechoic
Yes,
area
sir.
where you have this thing. And how will be the post-operative, morbidity? Will she have pain because of
So with
increased intra-ovarian pressure because of 2 ml of this fluid inside?
So, sir, ideally an ovarian PRP should be done laparoscopically. When you do laparoscopically, you can inject multiple points and cauterize, and then the risk of complications decrease, but the cost increases. Ultrasound guided PRP is a very mild, safe procedure, and it's like either giving them 3 months of adjuvants, you've just stimulated the ovary with PRP. So that's just a milder form of doing PRP. So that does not cause any post-operative pain. Patient goes home after 2 hours and hardly any complications. But yes, the effects of laparoscopic PRP are much, much better.
You are giving general anesthesia for it?
Yes, ma'am. Short general anesthesia.
So Dr. Manju wants to say
So,
something.
no, I just wanted to add, two of the gynecologists who were working in the Max, they started this project where they were giving it, PRP, and after 3 months, they were doing all other tests. And it did not work, and they just left this project.
Now, can I make a comment?
Yes,
Yes,
ma'am.
I think it is not possible. Only small ovary, transvaginal, you're misguiding your own colleagues, you're misguiding everybody. If you have to do it, cost does not matter. It has to be only laparoscopically. Otherwise, आप बेवकूफ बना रहे हैं लोगों का.
Ma'am, it doesn't work.
Madam, we have also tried in our own IVF center, and either you kind of stimulate the patient. I mean, आप clomiphene या letrose से cycle start करें, थोड़े
Yes,
cycle
ma'am.
में दिखने लगे with such a small poor ovarian reserve. Anyway, the ovaries are so small, and one is very, मतलब it keeps moving. It's not easy to inject. Also.
मैडम आप स्टिमुलेट कर लोगे तो वेस्कुलर हो जाएगा, ट्रॉमा ही ट्रॉमा हो जाएगा.
मैडम कम से कम follicles तो दिखेंगे, नहीं तो करना बड़ा मुश्किल काम है. It's not easy.
It's
We have
very,
also put up a
I
project.
agree.
If you're not
It's
doing
very
it,
difficult to
follicles.
see that.
आप अपने डॉटर पे करोगे, आप अपने डॉटर इन लॉ पे करोगे तो जरूर करो. नहीं,
नहीं,
this is
No,
this
no,
is
ma'am. It's not.
मैडम हमने
only
तो
the
एथिकल के लिए
follicles.
डाला हुआ है. We haven't started it, but when we मतलब होता है ना, before you the pilot study करना चाहते थे, तो we
Ma'am,
found it difficult.
Yeah. PRP is not done in the follicles, and PRP is not done for patients who have very small ovaries or very poor reserve. So there's a criteria for PRP. So you have to inject it in the ovarian stroma, so not the follicles, because if you inject in the follicles, then the effect will not
We are
come.
not injecting in the follicle. I meant was to make the ovaries visible. They are so
Increase the size
small,
of
you
the
know.
ovaries
With a
so
poor
that
ovarian
they
reserve,
descend in
anyway
the
the
POD.
ovary is very small, you know.
Ma'am,
Then-
transvaginal ultrasound, I don't think that you will not be able to see.
See, the
ovaries.
point is if they have real poor ovarian reserve, choice of patient is important, no? What kind
Yes,
of patient
ma'am.
are you
That's
taking?
for any adjuvant which you use. It's
But
subjective.
let's
to-
not discuss this particular topic.
So,
Let's
son,
move on to
you
something
just
else.
tell us what adjuvants we need to do in
Controversial,
what
ma'am.
dose and how many days.
See,
Clear, people.
yeah, if you want to give any adjuvant to see the effect in male, at least it should be, more than 70 days. Just giving for 1 week, 2 weeks is not going to help. And if you want to give an adjuvant to a female, because oogenesis takes almost 200 days. So you should give at least for 200 days plus. Then only you should expect the result. But just giving for 10 days, 20 days, or in your one, cycle prior to your IVF, you will not see the benefit.
And sir, dose of CoQ and all?
300. CoQ should be given 300. 100 milligram, is not sufficient. So you should give 300 per day.
And for 3 months at least, sir. 3 months.
They say there are 2 types of CoQ. One is more
ubiquinol, that activated.
That is activated one. So what is the dose of activated one, sir?
So that I think that comes at 100.
So that is 200 enough for a day, or that?
Yeah,
that
200 twice a day. Yeah.
Okay, 200 twice a day. So I think if anybody wants to make comment, otherwise we can.
I wanted
Sir,
to
even me. Sorry, ma'am. Madam, I found CoQ quite good. No doubt about it.
It is.
I also agree. I'm also using vitamin E and CoQ.
And vitamin C भी add
vitamin D.
Vitamin C
भी करते हैं, अब कर दूंगी, अभी मैंने सुना आपने.
You add amla, madam.
Yes. I agree with you.
Give
And
amla.
you must tell about the lifestyle changes.
Sir, kiwi fruit.
Yeah.
Beetroot.
Yeah.
So the basic of everything comes out to be that we need to change our lifestyles, जो बहुत difficult है. Very difficult.
नहीं तो डॉक्टर जोमेटो की तो बात जो कहते हैं, हम तो जब पेशेंट आते हैं ना हमारे इनफर्टिलिटी सेंटर में, मैं कहती हूँ अगर आप बाहर का खाना छोड़ोगे और बाहर का खाना मंगा के भी नहीं खाओगे तो ही हम इनफर्टिलिटी का ट्रीटमेंट करेंगे आपका.
That's very good.
करेंगे. So that they have to make a promise that they will not eat food from outside, because 90% of times their food is coming from outside. And I strongly feel that again you will like you will find my remarks very strong. Gynecologists who are not trained in infertility and IVF do more harm than good to their patients. This, I think, a message I wish to convey to everybody. Please go through different kind of courses which are available, which are cheaper than the fellowship which is being offered left and right by any kind of an IVF center. And I think once you get trained, you must know what guidelines to be used, what procedures has to be used. Your knowledge has to be absolutely thorough, and you should be skilled in seminology, andrology, and small procedures. So this is my request, is that Delhi Gynecologist Forum is running a great course, and each one of you who has not been trained, I can request that it costs peanuts in comparison to money which you pay for getting a fellowship which is of no use to you. I'm trying to be very drastic, but it is the fact of life.
So
thank you very much.
Thank you.
So I think we can close the session for today now. And before closing, I'll share one incident. One patient came to me and she complains me. I had given her only folic acid because she was not exactly infertility. And she comes to me, मुझे इतनी जलन हो रही है पेट में जब से आपकी दवाई खाई है. Suddenly मेरे दिमाग में आया, I asked her कि अच्छा आप नाश्ते में क्या खा के आई हैं? कह रही कुरकुरे. मतलब it was so funny. The whole OPD, all people, those who were standing, everybody had a good laugh. It's the state of affairs these days. Zomato को तो क्या कहोगे sir?
Swiggy आ गया.
Whenever I do IUI for the patients, just to divert their mind, I ask them, okay, you had your breakfast, your lunch. They would say, okay, yes, we had this. Then I ask, okay, what ingredients do you put into your that particular vegetable? Like राजमा आपने बनाया तो उसमें कस्तूरी मेथी डाली थी आपने? कहते नहीं सर, वो आजकल जो है हम नहीं डाल रहे कि मिलता नहीं. मैं कहा बेटा वो मिलता है, वो डाला करो. I guide them because it helps me diverting their mind, and also I try to introduce all these old spices into their food. So I think we all can do that, so that because we need to talk with the patient when we are doing any procedure without anesthesia. So that development gives a time to educate them. So this is what mission I have taken. I always ask the patient, my staff I said nowadays with the ART's bill coming, I may stop this and make a halwai ki dukan and make nice, because I know all the spices and how to cook rice, and how to kacha rice hai, fast rice hai, how to make that, purana rice hai to kaise banana hai. So I keep on teaching them, so that they, and we all should take this opportunity while doing any procedure on the patient, whether doing speculum examination also. So what food you have taken, and add whatever spices you would feel that is okay for that particular food.
शारदा
Yes.
मैम, एक हमें लाइव आई मीन फिजिकल कॉन्फ्रेंस करनी चाहिए वन डे की, टिप्स फ्रॉम डॉक्टर शर्मा, है ना?
That'll be a whole day long, Dr.
मुझे
Gunu.
डॉक्टर तलवार की बात याद आती है कि he used to say that when I used to get trained by Brigadier Sharma, मैं एक डायरी रखता था, क्या क्या बोलते रहते हैं सर. So I think this is all what the real guru is. That's why people like me always say that he is guru of IVF as far as the people are concerned.
No doubt, ma'am. No doubt.
He's a guru of IVF.
Thank you so much.
Thank you.
So I thank all my faculty, especially Dr. Brigadier Sharma sir, Dr. Manju ma'am, Dr. Sharda Jain, Dr. Neharika. अब ये नहीं कह सकती for coming all the way from Agra for taking the lecture.
No, Neharika, your presentation, I liked it when I heard it before, and you have modified it. I'm very glad about it. You stick to it. Every year I'm going to call you.
Thank you, ma'am. Thank you so much.
So thank you all.